sign soon. Sounds good. So our next session will be a keynote presentation on RM clinical reasoning by Michael Ridgway. Can we please welcome Michael to the stage?
I'll start with this and then probably just have to speak up loudly while I'm moving. Thank you, Dan. Now, this presentation is one that covers a topic that I find, what shall we say? I just spend a lot of time to try and figure out what it really is that the process of clinical reasoning does for a physio, does for clients. And so what I did then is spent my time saying, well, what is clinical reasoning really? Before RM, how would you have answered that question? Could you have put it simply? What would you have said clinical reasoning is? You can see it on the slide, what I would say now. What would you have said before RM training?
Finding dysfunction to have a diagnosis, but that would be probably patho-anatomical.
How to come up with a patho-anatomical diagnosis? Okay, yeah, that sounds reasonable. Fantastic, thank you.
Pattern recognition.
And what types of clinical reasoning are there that you know of? Pattern recognition is one. Thank you, Rick. Any others that you know of?
Treatment classification.
Yep, there is treatment classification. TBC, treatment-based classification, correct. Relatively new on the scene. Relatively. Deductive reasoning might be another. And I'll ask you to keep thinking about the others. You have to go back to, I know the fellow's name, textbook. James, sorry? Jones's textbook, yeah, go back. Look, so what are we after? Clinical reasoning. I figure it's problem solving. If you've solved a problem, whatever you did to get there clinically, you may have had to make some decisions. When you made decisions to solve a problem, you had to reason. There must have been a good reason for why you made those decisions. Hence, problem solving is clinical reasoning. So to make it easier for everyone to understand, I do prefer to call it problem solving. And you can see up there, what if a process, a standardized process, helps you problem solve the majority of clients? So what would that process be called? A version of clinical reasoning? Maybe. And because we use objective tests and only base logical decisions on objective measures, then RM terminology for clinical reasoning is objective clinical reasoning. So maybe when Jones does an update of his book in the next edition, we'll see if he can add this one to the topics. How are we going to demonstrate that for you today? Well, this is what I've got prepared for you. Fantastic volunteer, Steve, is over here. Now, this is what we've done. Steve had his NDT cleared yesterday. So we've already got up to a certain number of steps in the process. Now, even though we might got up to 24, I think we'll go back and we're going to start at 19 again, just so that everyone else gets a chance to see some of what was going on. Okay, so he's had his thorough assessment completed. What you've observed over there, Steve's already had done. So now I get to follow on from that with you. And the point of following on with it is for us to say what sort of decisions are being made and why with each step. And I would hope that you'll get very little complexity from this, and I would hope the decisions are made on very simple reasons and very objective ones, and anyone can come up with the same decision, logical and scientific. Okay, I'll end the mic and I'll speak just aloud from now on so that Steve can come on up. Thank you very much, Steve. And I've got to say, thank Caitlin as well for assisting as a scribe. So thank you, Caitlin. And when we, well, look, I'll read and we'll refer to what's on the whiteboard in just a minute. So I want to help you get to your goal of running 10 kilometres on consecutive days on the weekend. And I need everyone to help. If there's a change, we have to judge the percentage change. So what it was before to what it is now compared to how far it needs to go. Is there a change yet? And what sort of percentage would we be counting? 10, 20, 30? Somewhere in that range? More, less? 25%, thank you. So we'll record that. We have an idea now that something's connected to your hamstring at least, but we're not trying to infer any further implication rather than just what we saw. That's it. We have more steps to the process before we make any more judgments. And we'll continue other areas. What's next? Thanks. Now, I'd like someone, while I keep doing this, I'd like someone to sort of speak up and just say, what's the decision-making process I'm following? What am I doing in this? Bring it back to the basics. Bring it back to something really simple. I don't mean complicated physio stuff. I just mean, even if you were just to talk to a lay person off the street and say to them, do you think this is logical? What am I doing? Elimination's a good thing to do. Okay, yeah, that's good. Process elimination is good.
Things that work.
Comment that, is attributed to Thomas Edison when he was trying to find the filament of the light globe, and someone said to him, don't you get discouraged by the 2,000 things that have failed? And he said, no, I now know 2,000 things that won't work. So he's closer to himself.
Thank you. That's beautiful. So that's it. So this is the process we're following. If you think that's logical, if you think that's appropriate, you'd be happy to do this type of process. All right, so I've been asking you the questions about logics, about process of elimination, about whether the testing. The testing really needs to be objective for us to not let our judgments sway us. What sort of judgments might sway me? What do you think might sway me if I don't stick to just being objective? Who's got an idea of what judgments did I used to do 10, 12 years ago before I was doing it this way? Yeah, I did some judgments. What do I base things on? Experience. So if I hear you correctly, I'd be thinking whatever I saw in other people's bodies, I would judge might be matching this body. Is that correct? What do you think might have a potential fault in that judgment? Off you go.
Everybody's different.
Could be, what if everyone's different? What if I'm assuming too much? So assuming is the opposite of scientific. There was something else in that. We went through the assumption bit. What else did we? There was something else to my statement before. So I went through assumptions aren't helpful. So that was pattern recognition or experience. That was experience, that's right. What else might I have had from my past way that would, maybe not have been so helpful if I applied it in my judgments? What personal judgments may I have added to this process or to my clinical reasoning back then that wouldn't have been? Yeah, that's right. Research findings. Yep. So with low back pain, low back stiffness, tightness, what would research findings have told me to go for if I just use that alone? Now, I'm not ignoring them. I'm just saying if I just use that alone, what would I be doing, do you think?
Exercise.
I'd be doing exercise. And what if, what else, why might that not be ideal? It just may not be effective for this person. May be effective, may not. We just don't know. But what if we say, let's try exercise as a trial to see if it's influential for this person? Would that be good? Then we're using the research and saying we know it's effective. Why don't we see if it's effective for him? That's where we're getting rid of the assumptions. How do we go with that sort of process I just went through? Was it logical enough? What are you thinking, Russell?
I'm not clear what you're asking, Michael.
No, was it logical for me to say that even though the research is out there that says exercise is best, manual therapy is not best?
Big thumbs up there.
Who's got a thumbs up? Okay, go. Even though that's what the research says, would we be assuming too much if we just applied directly to this client? So isn't it better just to apply exercise to him to see if it affects him positively or not, rather than just do it only?
And that's like a homogenous group.
That's right.
Yeah. They're making assumptions about.
That's it. So let's not make an assumption that he fits the homogenous group that the exercise was best for. That's right. That's what I'm getting at. But it doesn't mean ignore the research. It means use the research. Just use it to apply to this fellow. So we'll do some exercise with you as part of the trial and testing. We call those MAWMs, muscle activations with movement. I'm doing right now. What am I doing now? Muscle release with movement. Can you go again? So it has some gains, but just not as good as the disc.
No.
That was the second time I tried that. And go again.
Well, the positives, I guess, about this model, Michael, is that you are getting such a range of objective measures that really you can compare anything.
That's right. Yeah, we could read him a storybook and see if it makes a change. We could put TENS on him, ultrasound him. We could do anything to him. Yeah, close his eyes and
It gives you...
visualize. We could do anything. Thank you, Greg. That's a really good point. Go. So anything in your toolbox, give it a go, is where we're coming from. So that way it's inclusive of anything possible. We're not going to be exclusive and deny anything that could work. Go.
Just help me there.
Okay, that was good amount. Still extra or same? Same. I think you said same. Yeah, RF, RI. What are we up to next? And this is tricky. We've got to try and think all of the time, what could I be doing that would fudge it or give a false negative or a false positive? Just think all the time, is there something I could be doing that would give a false positive? And if you think like that, then at least you have a higher chance of just not missing accidental measures. So what could be happening here? I'm doing a release on his leg and holding the leg. And this is the part that's being tested. So I could give a false positive just by fudging it, couldn't I? What could I do? Just put a bit of force into it. So just keep all those in mind, but at least when you let go, you're not touching it anymore, so the retest will be a good indicator. So don't worry about it, is what I'm saying. Off you go. Just do your best. Fabulous. So as a client, even though you're a physio, even though you're on a course in front of people, in the audience, what do you really get a sense of while we're going through this? Can you talk to me about, just tell me what you're going through while we go through this whole process? What does it mean to you? How meaningful is it? That type of thing.
Oh, it's very meaningful because it's a thorough examination, which helps to exclude possible causes.
Keep talking up, thanks. Talk up loud.
Yeah, possible causes, but of course, there is a little bit of, yes, there's lots going on. I suppose at this stage there's maybe a disconnection to my good result still, because even though we may get a good result here, this is more of what you would like to see, even though I can see it's a good thing for me. I mean, obviously I haven't got to the end of the session or to the process yet, but there's that still, I won't say murky connection, but it's not, the synapses haven't connected just yet.
Good. How did everyone go with that? Could you hear that, Josh? Perfect. So we do need some patience to be able to get to a next step, don't we? So it's the right time to speak to you and say, because we've got to wait till tomorrow before we continue the process, it's the right time to say, well, what can we talk about, discuss to see, not because it's going to prove anything to you, but just to at least give you a plan so that you know what to look forward to, so that when we can link it to your good result, then it'll become more clear. But then what's the steps in the meantime? So if we can just give you that, you can go away and come back and we'll go through some more. Yeah. More motivated, more excited just to get on with this, even though it's very isolated and localized and very physio-centered at the moment. Yeah. Yeah? So what would we talk through? Who's got an idea? And we're going to finish up. Who's got an idea of the plan that we're going to say? What do we do? What are we going to say? Which says, between now and the end of tomorrow, I'd like you to know what we're aiming for so that you can look forward to what's going to connect to your running. Anyone got some suggestions of what we'd say?
you'd say, well,
Go.
you'd say, look, we haven't finished yet. Obviously, it's a whole process.
Yeah.
Found.
Come on up, sit up, face everyone. Yep.
Face, oh, I was being treated. I mean, well assessed. I mean, I'd say to someone,
Thank you.
you know, you've got so many things wrong with you. Yes, there are two amazing things that you've got right, but it's still what's wrong with you. We've only got to this step of the process. So, as I said earlier to you, are you excited to find out what is the cause of your good result to get your good? What's the cause of your problem to get your good result? So, unfortunately, we haven't got time to do everything.
That's okay. No, I'll say fortunately we've got a lot done today. Fortunately.
Well,
Fortunately we'll get even more done again tomorrow. That's right. Positive. And, okay, so the next step, I'd say, please let's look forward to the next step. The next step is to find out what the best thing is that'll help your hammy. Now, we don't know what that connects to yet.
Yeah.
So if that connects to all of the things that are contributing to your back problem, then all of the other things contributing to your back problem and your hammy problem will also come good once the hammy comes good. So we're using the hammy to indicate what it could be. Now, if all of those things come good, you told me what you think would happen to your running. So we're in the middle of just getting to that step. So maybe by the end of tomorrow, we'll see.
Sure.
If we can get there.
Okay.
If not, don't worry, it'll be soon after. It'll be the next day. Okay?
Yeah.
How motivated? How soon do you want it? How much do you want it?
Right now, let's do it.
Okay. Can we all... Thanks, Steve. It's just amazing. Thank you.
Okay, so can you please welcome Michael to the stage again?
If everyone can remember where we were yesterday, what did I describe the lay term for clinical reasoning is? That's it. We've got started. Do we agree that what I'm doing is objective tests or objective retests? If you do, that's great. What makes it objective is what I'll ask you to get very solid on so that you can be confident that's what you do for yourself. Now, what is my decision-making process? I asked you a couple of questions yesterday to see if they were logical, if they made sense to you, and if we weren't assuming too much. So please keep thinking like that and see if you can find any assumptions I'm making. It was good for the client to say he couldn't quite see the process connecting. How'd you go since yesterday? Can you tell us whether that was a satisfactory answer or not, or whether you still have a question about the process we're going through to get you running?
I'm still at that point.
Still at that same point?
Yeah.
Good. I like never being wrong. Anyone else like never being wrong? Yeah. Look, it doesn't mean I'm right. Don't worry about that. I'm not trying to say that. But I'm just saying I'm never wrong. Unless, of course, you know, my wife tells me something different. And that's okay to be wrong in that situation. Okay, but clinically, if I stick to the process, I'm never wrong. Because every question I ask and everything I attempt to do is a self-fulfilling sort of process. As in, I never try to assume or predict something which can then go wrong. Everything we're doing is just what will happen. Let's measure and see. And if we measure and see, we're always being scientific. If we predict something has to be a certain way, or we assume it's going to be a certain way, there's a chance we could be wrong. So let's avoid that one. If you're all up for it, I am. Thanks. Okay. Thank you. All right, next one, please, Caitlin.
Can I just make a comment on that?
Yeah.
We did the TDT with the transversus and no significant effect.
No, yeah.
So we could say to Steve, now look, we just saved you 6 weeks of Pilates.
Yeah, it is like that, yeah. Yeah,
It didn't help your...
I've certainly done it. I've had some clients who are wanting a faster result because they have a competition soon. And the coach said, Michael, do you think you can do any better than the 12-week rehab program of transversus that the physio's got him doing? And I said, I'm pretty confident. Yeah, give me a go. It'll only take me a couple of hours, I'll tell you. And yes, you're right. Did that, the TDT didn't change. So then I did some other, tried some other TDTs, and one made a massive difference quickly. Within 3 days, he was fixed and he was off to his competition on the weekend. So yes, we avoided the 12-week transversus training program for that reason. I have had someone whose transversus was the PCF. And as soon as I activate it, TDT just went amazing. And so, look, just don't assume anything. Just give it all a go is what I'm trying to come from. What would you think if I tell you that it is very, very possible to get better results than I can with RM? What would you think of that?
Impossible.
Thanks. Well, time again to... Now you should be speaking with Jessica. So I think she'll tell you she's noticed some times where she'll get better results than me. Dan, where's Dan? He hasn't told me yet, but I'm suspecting he thinks the same. Where is he? Oh, he's over there.
He's nodding.
Now's that time. So what am I asking about? The purpose of starting off that kind of discussion was, what does it take to get the best results possible with RM? That's kind of where I was going.
Practice.
And yes, you're right, it's practice with something. So really what I'm trying to get at is there's two things you might quickly think about. One might be skill set, and there's another one which I find trumps that a lot by a long way. Process, follow the process. Who said that? Two people? Two people. So how well you commit to each step dictates how good the outcomes are. I'm saying on average, it trumps skills. So while I want everyone to get better at the skills, I'm going to keep working on my skills as much as I can until I retire. But while everyone should get better at the skills, if you actually just make sure you do each step as accurately as you can, then the outcomes will be significantly improved. Much more so than just working on how good your skills are. If your skills are amazing and you don't follow the process accurately, the outcomes won't be that great. At worst, like let's just say I'm a very lay. That's very lay psychological strategies. So if we exhaust everything else, you've got options to go to next. An option next might be a psychologist to help you, or a hypnotherapist, or someone just to help you get a change in that, and see if then it relates to your problem. Is everyone okay with that as an ongoing sort of next step? So it just helps us know there's a dysfunction there. If I can't fix it, someone can. Okay, so that sit-up one would be a good one. If I did muscle testing as typical everyday testing, I would have done sit-ups and other muscle strength and things like that as part of my assessment. So please also note, whatever you've got in your toolbox to do as your assessment, you just include that. If you've got real-time ultrasound, with this one or this one or this one? Oh, it's this one, right?
Both pretty good.
Did that. Okay, where are we up to? We've exhausted the list, and we've got 3 on the list. What do you think's logical? Let's go with logics. We don't want to assume anything. If we've got 3 that have given us the best benefit for just a test so far, what do you think we should do next? Someone who's not trained in RM, what would your logics tell you? 3 that are, okay, pretty good really, but we don't know which one's the best yet. What do you think we should do?
Treat the most effective one
First, and then do what next?
Then see how you go, and then treat the next effective one.
And then?
The third one.
And then find out which is the best one. I think that's logical too. So we're still trying to be thorough by not trying to assume anything too quick. We just want to keep testing until we prove something is the best. Good, thank you. Which one? Now, what I like to do to be more, there's still going to be some assumption in this, but I'm going to reverse the order effect. So just in case there's an order effect. So, if you always did, what were the order of them? If you always did this, and then masseter, and then this, each time you test, you're not sure if the order effect is, you might be missing something. So we just do the reverse order, or change it up, and then you can get what you'll find is 1 is best, is what I'm trying to get at. So the way to get 1 is best is to go back over them again, and reversing the orders, I've found a pretty effective thing for discovering that. Hey?
Do you need to set a baseline
Yeah,
again?
yeah. Go baseline. Now, as a client, what did you think of having something released and feeling that change?
It felt good. It actually felt nice and light and easy.
So light and easy is nice.
Yeah.
Yeah. And is that the opposite of stiff and tight?
Yes. Is it? Heavy and no.
It
is. Because I have been feeling, we've talked about this catching, and that doesn't feel like it wasn't catching. It's probably, I want to continue. So we're going to ask you a question?
Yeah, good clients start doing what you need to do before you have to ask them. So that's what happens. They say, come on, let's keep working on this. So please, if you are comfortable with that, we've done our treatment direction tests on all your dysfunctions, then you would check that box of 24. And if you're comfortable that we measured the significance of the change for a test, or for 2 tests now, with the TDTs, yep, you got that one?
Yep.
Why is the next step to reassess all of those signs again?
In case something you've done has changed something else.
That's right. So logically speaking, if you were to sort of paint a picture about what you think's going on, if you could objectively measure a certain number of these, if not all of them, but a number of them, all change significantly, similarly significant to the hamstring change. What percentage did we give that in the end? Sorry, in the end, from before to after, what do we give the hammy change in total? Did someone judge that for me? I don't like to judge it because otherwise I'm putting words in your guys' mouth. I'd rather you be in control of it. That way I'm not getting it. 5, 6.
87.
Nice number. 87%, guys. We got it? 86.6 recurring or 87? Okay, no, it's okay. Can you put it down as that's it.
As what?
87%. Put it down. So we got an 80%, 7% in one change. So what we're talking about with grading changes is it has to be dramatic enough for the client to know it changed. It's none of this sensitive physiotherapy hands that can tell you a millimetre of movement here or there. It's about the client knowing that's a big difference. So the client knew that's a big difference. Yeah. So we only rate those, or if the physio helped the client know it's a big difference because they couldn't see it for themselves, so you take a photo or you help them. So it's got to be a big difference to count. How's that sound? Is everyone okay with the logic of that? That gets rid of less of the subjectivity of whether that PSIS is a millimetre high, centimetre high on left or right. Anyone done any inter-tester reliability studies with that in your classes before in prac? Anyone know what happens when you do that? Anyway, we did. It was as good as guesswork, unfortunately, when we did it. So what we're trying to say is if a client couldn't tell the difference, we don't count it. Okay. So do all the things you need to prove stuff is what I'm trying to get at. Prove it. Don't fudge it is where I'm going. So a thorough reassessment of everything. What would you get out of it if 2/3 of those signs all changed? Doesn't matter where they are or what they are, but 2/3 of them all changed somewhere in the region of 50%, 80%, just a lot. What would you take away from that, Richard? Anyone?
That's a very powerful.
Steve? Okay, thanks. That's the sort of logic. Something was significant. That's the sort of logic I think is reasonable.
Those 2/3 are likely part of his condition.
And correct. You're right. But I haven't quite shown the relationship completely direct yet, have I? Because you know what? I treated some of those spots as I went. So what if I fudged that? What if treating one of them loosened them up? So we go back and test it, and now it's looser. So let's prove it. So how do you prove it? More treatment on the thing you think that did the best result. You go back and reassess them again, and if they keep improving, if all 2/3 of them keep improving every time you treat just one thing only, then I think we've got a more conclusive answer for what you just mentioned then. So this is just the logics. If we can stick with logics, and that's just 100 now?
You're adopting the...
Yeah, I'm trying to. Just to make sure I lock it and don't accidentally cheat. Because you know how you can cheat? You just drift it out to the side. Oh, that's nice, isn't it? That's a big improvement. So no, don't treat. I keep it like locked in, midline. Small change, not big enough to put down as big one, correct? Look, you guys override me. I'm needing you to all agree, and therefore we've got a better consensus. Yeah, we did that one. That one improved significantly, so put that one up there. Yep. So,
4.0.
yeah, thanks. 4.0. And so what we can do is, as Caitlin's doing, you can use different colours. Circle green for the things that changed and circle red for the things that didn't. Don't even have to write any more notes. They're all written down on the form. And I've got these muscles, and it was a dramatic lock, so it should be repeatable to test. And off you go. Yeah, so we're getting curved now to there. And you can tell, hey? You get the same point, or you get the same internal sensation
Yeah, I don't
at the
know
point of stop.
where it looks.
Yeah, we just have to say, can anyone help you judge from yesterday? Different or not? Yes, it is. Yeah, side count, that one is significantly different too, so circle that one green. And single leg squat, the important one in the end, you know, for what we're really going to get to. And go. Okay, coming back up. I've got to try and pick where the spasm kicks in now. Go. There. Bang. And back up. So, different? By maybe more like only 30%. All right, so that's my demo. That's my presentation for you. Please think of as many challenging questions as you possibly can and put them all on Facebook or catch us before tomorrow evening. Have I helped some people get some of their good results about what you can do to leave this conference and get clinically better results?
Yes.
Yes? How much have I helped? With a clap of hands, please. Go. All right. Thank you. Thank you.
Thank you very much.
Please, champion. Well, even if melodramatic, champion. Thank you. Right, thanks.